heat source to the body. Depth of the injury depends on temperature of burn and the duration of contact with it. Burns disrupt the skin, which leads to increased fluid loss, infection, hypothermia, scarring, appearance, and body image. Young children and elderly continue to have increased morbidity and mortality when compared to other age groups with similar injuries. Inhalation injuries, in addition to cutaneous bone, worsen the prognosis. Burn depth and breadth. The depth of the burn injury, active agents, temperature of burn agent, duration of contact with the agent, and skin thickness. Burn are classified according to the depth of the tissue destruction. Superficial partial thickness burns similar to first degree, such as sunburn. The epidermis and possibly a portion of the dermis are destroyed. Deep partial thickness burns similar to second degree, such as scald. The epidermis and upper to deeper portion of the dermis are injured. Full thickness burns third degree, such as burns from a flame or electric current. The epidermis, entire dermis, and sometimes the underlying tissue, muscles, and bones are destroyed. Superficial, deep partial, full thickness, extent of the body area burned. How much total surface area is burned is determined by one of the following methods. Rule of nines. An estimation of the total body surface area is determined by assigning percentages in multiples of 9 to the major body surface. 192, 18, 9, if it double, 18. And next is and broader method, a more method of estimating the extent of the burn, taking into account the percentage of the surface area represented by various anatomic parts, head and legs, changes with growth. Palm method used to estimate percentage of scattered burns using the size of the patient palm, about 1% of body surface area to assess the extent of burn injury. Gerontological consideration. Elderly people who have higher risk for burn injury because of reduced coordination, strength, and sensation, and changes in vision, predisposing factor, and health history. The older adult influence the quality of the care of the patient. Pulmonary function is limited in older adults, and therefore airway exchange and lung elasticity and ventilation can be affected. This can be further affected by the intensity of smoking. Decreased cardiac function and coronary artery disease increases the risk of complication in elderly patients with burn injuries. Malnutrition, mellitus, or other endocrine disorders present nutritional challenges and require close monitoring. Varying degree of orientation may present themselves on admission or through the course of care, making assessment of pain and anxiety a challenge for the burn team. The skin of elderly is thinner and less elastic, which affect the depth of the injury and its ability to heal. What is alert? Education on prevention of burn is especially important for the elderly, as elderly patient ability to safety ideals, assisting elderly patient and family to modify the environment to ensure safety and make referrals as needed. Medical management for course management and prevention institution and saving of life measures for the severely burned person. Prevention of disability and disfigurement and rehabilitation. First is severely burned. So we have to prevent the disability and disfigurement and rehabilitation. And so for the management, first one is resuscitative phase, which focuses on the assessment. The burn wound is secondary consideration, although aseptic management of the burn wounds and invasive lines continues. Assesses circumstances surrounding the injury, time of injury, mechanism of burn. If the burn occurred in closed space, the possibility of inhalation of noxious chemicals, and in a related trauma. Assesses circumstances surrounding the injury, time of injury, mechanism of burn, what type of burn is occurring, whether the burn is occurred in a closed space or is the patient the chemicals, or it has internal lung damage. Monitor vital sign frequently, monitoring respiratory status closely, and evaluate apical and carotid and femoral pulse, especially in area of circumferential burn injury to an extremity. So vitals can be evaluated at apical, carotid, and femoral pulses, particularly in area of circumferential burn injury to an extremity. Start cardiac monitoring if indicated. History of cardiac or respiratory problems, electrical injuries. If there is cardiac, So we have previous respiratory problems and critical injuries. Check peripheral pulses on burned extremities hourly. Use Doppler as needed. Then to an extremity, check peripheral pulses on burned extremity hourly. Use Doppler as needed. Monitoring fluid intake, IV fluid on output, urinary catheter and measure hourly. Note amount of urine obtained when catheter is inserted. Indicates pre-burn renal functions and fluid status. Assess body temperature and body weight. History of pre-burn weight, allergies, tetanus, immunization, past medical surgical problems, current illness and use of medications. Checking the peripheral pulses on burned extremity hourly using Doppler as needed. Next is IV intake and output and measure hourly. Note amount of urine obtained when catheter is inserted. Indicate pre-burn renal functions and fluid status as body temperature, body weight, history of pre-burn weight, allergies, tetanus, immunization, past medical problem, current illness and use of medications. Arrange for patient with facial burns to be assessed for corneal injuries. Continue to assess the extent of burn, assess depth of wound and identify area of full and partial thickness injury. Assesses neurological status, consciousness, psychological status and pain and anxiety levels and behavior. Assessment patients and family understanding of injury and treatment. Assesses patient supporting system and coping skills. Conscious psychological status, pain, anxiety and behavior. Intervention. Promoting gas exchange and airway and monitoring arterial ABGs. Pulse oximeter and carboxyl events. Assess breath sound and respiratory rhythm and depth and symmetry. Monitor for hypoxia. Observe for signs of inhalation injury, blistering of lips or buccal mucosa, cyanosis, burns of face, neck or chest, increasing harshness or soot in sputum or respiratory circulation. So what is the intervention? Report laboratory respiration, labored respiration, heart respiration, decreased depth of respiration is a sign of hypoxia, typically immediate repeat infusion or carotomies. Monitor mechanical ventilator patient closely. Institute aggressive pulmonary care measures, turning, coughing, breathing, deep breathing, periodic forceful inspiration using spirometry and tracheal suction. Maintain proper to promote removal of secretion and airway and to promote optimal expansion using artificial air as needed. Restoring fluid and electrolyte balance. Monitor vital signs and urinary output hourly. Central venous pressure, pulmonary artery pressure and cardiac output. Note and report sign of hypovolemic or fluid overload. Maintain IV lines and regular fluids at appropriate rates as prescribed. Document intake and output and daily weight. Evaluate the head of the bed and burned extremities. Monitor serum electrolyte levels, sodium, potassium, calcium, phosphorus, bicarbonate, recognize in developing electrolyte imbalances. As prescribed, document intake, output and daily weight. Evaluate the head of bed and burned extremities. Monitor serum electrolyte levels, sodium, potassium, calcium, phosphorus, bicarbonate, recognize developing electrolyte imbalances. Notify physician immediately of decreased urine output, blood pressure, central venous, pulmonary artery or pulmonary artery wedges pressures of increased pulse rate. Provide warm environment, use heat shield, space blanket, heat light or blanket. Assess body temperature. Pain scale tests pain level, differentiate with resistance to pain, resistance to seizure, use IVA, opioid analgesic listed, assess response to medication outside for respiratory depression patient who is not mechanically ventilated, provide emotional support, reassurance, simple explanation about procedures, assist patient and family understanding employing coping strategies, family dynamics, anxiety levels, provide individualized response to support patient and family coping, explain procedure to clear some terms, provide pain relief and give anti-anxiety medication if they remain anxious and agitated for brain intervention. Monitoring and managing potential complication. Acute respiratory failure assess for increasing dyspnea, steroid or changes in respiratory patterns. Monitor pulse oximetry and ABG value to detect problematic oxygen CO2. Monitoring chest X-ray assess for cerebral restlessness, confusion, report deteriorating respiratory status immediately to physician and assess as needed with intubation or echotomy. Distributive shock, monitor for early stage of shock, decreased urine output, cardiac output, pulmonary artery pressure, pulmonary capillary bed pressure, blood pressure, increasing pulse or progressive edema. Administer fluid resuscitation as ordered in the findings. Continue monitoring fluid status. Acute renal failure, monitor and report abnormal urine output and quality, blood urea nitrogen and creatinine levels, assess for urine hemoglobin and myoglobin, administer injected fluid as prescribed, compartment syndrome, assess peripheral pulses hourly with Doppler, assess neurovascular status of extremity hourly, capillary refill sensation and movement, review blood pressure cuff after each reading, elevated burned extremities, report any extremity pain, loss of peripheral pulses or sensation, prepare to assess with echarostomies, bowel sound resumes, bowel sounds, curling ulcers, assess gastric acidity with blood based and acid and histamine blockers as prescribed, nursing management acute intermediate phase. The acute intermediate phase begins 48 to 72 hours after the burn injury. Burn wound care, pain control are priorities of the stage. Assessment focus on the hemodynamic alternation, wound healing, pain and psychological response, and early detection of complications. Measure vital signs frequently, respiratory and fluid status remain highest priority. Assess peripheral pulses frequently for first few days after the burn for restriction. Closely observe hourly fluid intake and urinary output as well blood pressure and cardiac rhythm. Changes should be reported to the burn surgeon promptly. For patient with inhalation injury, regularly monitor our conscious and pulmonary function and ability to ventilate. If patient is intubated and placed on ventilator, frequent suction and assessment of airways are priorities. Intervention restoring normal fluid IV, oral fluids, IV infusion pumps. Report changes blood pressure per strict decision. Preventing infection. Provide a clean, safe environment. Protect pain from sources of cross contamination. Clean closely. Detecting monitor results and white blood count. Clean technique for wound care process and accept for any invasive procedures. Use meticulous hand and after patients. Caution to avoid touching wound or wash unburned areas. Change hands regularly. Aggregate nutrition. Initiate oral fluid slowly when vowel sounds resume. Record tolerance if vomiting and digestion don't occur. Food may be increased gradually and the patient may be advanced to a normal diet or tube feeding. Collaborate with dietitian to plan a protein and calorie-rich diet acceptable to patient. Encourage family to bring nutrition and patient's favorite food. Provide nutrition and vitamin and mineral supplement if prescribed. Document calorie intake inside feeding tube if caloric goals cannot be met by oral feeding. Or continuous or bolus feeding, not residual volumes. Weigh patient daily and graph weights. Assessment distress and painful wound care. Coordinate complex aspect of wound care and dressing changes. Assess burn for size, color, order, exudates, epithelial buds, small toys like rustral cells and wound cells. Bleeding granulation tissue, the status of graft take, healing of torn site, and the condition. of the surrounding skin, reporting significant changes to the physician, inform all members of the healthcare team of latest wound care procedures in use of for the patient, assist, instruct, support and encourage patient and family to take part in dressing changes and wound care. Early on, assist strength of the patient, family in preparing for discharge and home care, relieving pain and discomfort, frequent pain assessment, analgesic assessment, and anxiety in anxiety, preparing a severe, patient medication, prevention, relaxation technique, control over mood care, analysis of frequent reactions, guide imaginary distraction to alter patient perception and response, hypnosis, music therapy, virtual reality are also useful. Assess the patient's sleep pattern daily, administer sedative prescribe, work quickly to complete treatment thus changing, encourage patient to use analgesic medication before painful procedures, promote comfort during field phase. The following oral and antibiotic agents: a cool environment and frequent lubrication of the skin with water or silica-based lotion. Exercise and sprinting to prevent skin contracture and diversional activities. Promoting physical mobility. Prevent complication of immobility, atelectasis, pneumonia, edema, ulcers and contracture. Deep breathing, turning and proper repositioning. Modify intervention to meet patient needs. Encourage electricity ablation when legs are involved. Apply elastic pressure to bandages before assessing perioperative position. Make aggressive effort to prevent contractures and hypertrophy scarring in wound after wound closure for a year or more. Initiative passive and active range of motion. Exercise from admission and engraftment within prescribed limitation. Apply sprain or functional device to extremity for contracture control. Monitoring for signs of hospital insufficiency, nerve compression and skin breakdown. Strengthening coping strategy as patient to develop effective coping strategies. Set specific expectation of behavior. Promote truthful communication to build trust. The patient practice coping strategies and give positive information when appropriate. Demonstrate acceptance to patient. Investigate non-default person for patient to learn feelings without the fear of retaliation. Include patient decision regarding care. Encourage patient to assert individual preferences, etc. As patient physical care. Support make psychological information of the burn care and expected course of treatment. Initiate patient and family management, assess the consideration preferred learning style. Executive teachers remain sensitive to the possibility of changing family dynamics, monitoring and managing potential implications. Heart failure, assess for fluid overload, decreased cardiac output, oliguria, digital vein dissection, edema, and onset of S3 or S4 heart sounds. Pulmonary edema, assess for increasing CV, pulmonary artery and wedges and cracked bone. Report promptly position comfortably with head elevated use unless contraindicated. Administer medication or oxygen prescribed as response. Sepsis, assess for increased temperature, increased pulse, widening pulse pressure, and flushed dry skin in unburned area. Early signs and not trend in data. Perform wound and blood culture as prescribed. Give scheduled antibiotic on time. Acute respiratory failure and acute respiratory stress syndrome (ARDS). Monitor respiratory pattern and onset of adventitious sound. Assess for decrease in tidal volume and lung complaints in patient on mechanical ventilation. The hallmark of ARDS is hypoxemia on 100% of oxygen. Decreased lung complaints and signaling shunting and notification of decreasing respiratory status. Visceral damage from electrical burn, monitor electrocardiogram and report dysarrhythmia. Pay attention to pain related deep muscle ischemia and report. Early decision may severely complicate. Fascia may be necessary to release swelling and ischemia in muscles and fascia. Monitor patient for excessive blood loss, hypertension, report septomy.